And I will turn off. Okay, so you're being recorded now. I will turn off my video because of the internet connection. Please forgive me, and I will share my screen. Okay, I hope you can all see the screen now. And what I mean to show you. All right.
Professor, are we having the quiz first, or are we going to have a class first?
Oh, we do have a quiz. It's true. I totally forgot. It's true. I almost forgot about it.
Just a small request. If we could have the quiz first, that would be great.
Yeah, good idea. Let's do the quiz. Okay, then I stop sharing again. No. Stop sharing. Here we go. Okay, let's do the quiz first. Okay, so stop the recording. And let's carry on. All right, the quiz wasn't too terrible, right? Wasn't too bad. I hope everybody did well. I will go one by one through the questions in case there are any ambiguities or any potential alternate responses, but I think in that case, this doesn't apply for this test. But yeah, we'll go one by one through all the questions. In case there's anything to revise, I will revise that. Okay, so we will be talking today about quite an interesting topic that essentially also has kind of been very much discussed in media and in the context of, so I will stop my video. In the context of the pandemic, this has actually become really quite a topic because the application of probabilities is essentially what is needed to quantify the characteristic of a test, as well as the characteristics of a test in a particular population. And for that very reason, there has been quite some discussion about sensitivity, specificity, positive predictive values, negative predictive values, post and pre-test probabilities, and the application of tests to a population. So this is what we will be discussing today. We're using different examples. We will not be talking about COVID-19, but we will talk about topics that essentially relate to what had been discussed in the context of COVID. So as said, so we are on session 6. We're talking about screening tests. We're talking about sensitivity, specificity, PPV and NPV, which are two super important values that are particularly important in the context of using tests in populations. We will be talking and discussing prevalence and to what extent this actually translates into a probability. We will briefly touch on properties of probability and conditional probability in the context of did I lose all of you? No, everybody's still here, right? Okay. Okay. All right, and the applications of probabilities on tests. And then we will talk about conditional probability and Bayes theorem, to what extent this actually translates then into the use of screening tests. This all relates to the statistics section 2 of the open entry book. So the application of a probability, for example, is now consider a screening test. A screening test that is correctly positive for 100% of all cancer patients, meaning that if you use it on a cancer patient, this test will be positive by 100% probability. So now we're looking at a population where the prevalence of cancer is 5 per 1,000 per year, which translates essentially in a probability of 0.5% that from a population, you will pick one random person suffering from cancer. So now if you use this test now to the general population, who wants to take a guess what the probability will be that an individual testing positive actually really has cancer. Based on what's written here, based on what you know about this test and the population, what would I say is the probability that a positive testing individual has really cancer? Any guesses? Okay, since nobody takes a guess, reveal it, which essentially is we don't know. We don't know because essentially we're using this test also to 9,995 healthy people, which potentially could be testing positive as well, which is, and we will talk about this later, a so-called false positive measured individual. So the probability of an individual with a positive test depends on the performance of a test on the individual that does not have cancer. And only once you understand that, you can actually characterize the performance of this test on a population. So it also depends, and this is where positive and negative predictive value comes into place, and the pre-test and post-test likelihood and Bayes theorem, as we will see later on the prevalence of cancer in this population. So it is important that you understand how frequent is this disease that you're trying to diagnose. Ideally, every test would be 100% accurate, obviously, right? So you basically want a test that really 100% with 100% certainty identifies a person that does not have the disease with a negative test, and those that do have the disease as having a positive test. So now the problem is this is in most cases not possible with most tests. So at least I'm not aware of one, and I don't think this is really possible. So if you have a false positive, you have somebody that tests positive but does not have the disease. As you can imagine, this comes with a lot of problems because you're diagnosing somebody as having a disease, which hypothetically may require surgery or may require all kinds of invasive procedures, but that individual essentially does not have the disease. So then on the opposite, you have the trade-off. You have false negatives that essentially test negative, but on the other hand do have the disease and you don't identify it. So in the case of cancer, this is obviously a huge problem because that individual, you send him home or him or her home, and you say, you're healthy, you're fine, you don't have the disease. So this is a problem as well. So it's really this, this trade-off between both, which we'll discuss later on, which depends on the test, on the purpose of the test and the way you're applying the test, and as well the population you're testing it on. So the performance of the test really depends both on the test and on the population. And this is important to always keep in mind. So I mentioned before the so-called pre-test probability and the post-test probability. And this is where Bayes theorem comes into place. And we will talk about this in a second. But now consider that you have a population and you know you have a population that comes into your office where you know in this population the disease is 30%. What is your pre-test probability? Logically, if you point at any random person coming into your office, you have a 30% probability that individual will have the disease. On the other hand, you want to have a post-test probability of a positive test, depending on this pre-test probability, and you would want to increase this to a maximum to essentially understand whether your applied test and your test employment essentially really resulted in an accurate result. And this is really, this conjunction of these probabilities really lead to a post-test probability that really allows for you to diagnose a disease with an acceptable level of certainty. So this being said, so it depends on the population and it depends on the test. All of these diseases, all of these disease tests, all these tests that we're basically talking about are always compared to what is called a gold standard. A gold standard in most cases is an extremely highly accurate test comes with the downside that either it's really expensive or it's very invasive or it's both. When you think about some certain diseases, for example, it comes down to cancer. Okay, let's stick with the example of cancer. So we have a cancer test that allows for us to diagnose in a population where we know a certain probability. We're using the test to diagnose the presence of a tumor of cancer with a certain probability. But that expensive, invasive test would essentially be to really surgically approach this tumor and extract it, cut it out, and essentially have an histological assessment of this tumor. So this would be the very invasive test. So hopefully there will be tests that come with a certain post-test probability if employed to a population with a known pre-test probability and a clinical presentation to come to a post-test probability to spare this invasive, painful procedure of a surgery to a large number of patients and not have to have every patient undergo surgery. So this is this trade-off where this is really important to keep in mind, for example. Just as an example, it's a very extreme example, but it's basically well explained using this example. So all of the tests we're looking at are essentially compared to gold standard. So as an example from the COVID world, for example, you may have heard of a rapid antigen test, which essentially is a test that diagnoses COVID with a certain amount of certainty, which is unfortunately lower than you would hope it would be. And then the quote-unquote gold standard test essentially would be a so-called RT-PCR test that essentially takes 24 to 72 hours of turnaround time because it needs to be measured in a real lab and it requires a real assay and it's expensive and it takes long. So this being said, and this making this an actual example from our current times. So the application of probability. So let's move from cancer now to a second example. So what you see here in front of you is a so-called 2x2 table, a 2x2 contingency table, which essentially is something that we will construct later on in the lab. And this is something that you will see very frequently in the world of epidemiology. So the way this is always designed is you have on top, building the top x-axis, you have the actual disease. So on top you have the disease. You have on the left side, you have positive. On the right side, you have negative. So you have two columns. This is the positive column and this is the negative column. And you have on the quote-unquote y-axis, so as building the row, you have the actual test that is being employed. So this is a PCR test, a polymerase chain reaction test to test for chlamydia. So essentially you have positive in the top row and you have negative in the lower row. So the way you have to read this, you have here positive and positive coming together. And this is labeled a so-called true positive. If somebody tests negative and really does not have the disease, this would be this group of patients here. This would be labeled as true negatives. If you have somebody who is actually suffering from chlamydia and tests negative, would be here, this left lower quadrant. This essentially would be a so-called false negative because the test shows the individual is negative, whereas the individual really has the disease. In contrast to that, you have somebody who is negative for the disease and tests positive, which is a so-called false positive. So now this is true for both of these groups, but what you see here, quite impressively, you see that, and here the positive predictive values that essentially are depicted here. And so you have predictive value positive and predictive value negative. So just as a quick, so I'm jumping ahead here a little bit. So positive predictive value is calculated by the positives divided by the sum of the positives and the so the sum of the true positives and the sum of so it's the true positives divided by the sum of true positives and false positives. So all those that tested positive build the denominator. Those that did test positive and are actually positive build the numerator. So this would be 294 divided by the marginal total of 315. Whereas the predictive value negative here would be 679, so true negative, divided by 685 marginal total between true negative and false negative. So as you can see, in a population where you have a very high prevalence of a disease, here in an STD clinic, you essentially, with a prevalence of 30%, this is quite a high prevalence. So you have, of 100 people that are coming in your office, you basically have a 30% probability that 30 will be, so 30 of 100 would hypothetically carry the disease and would suffer from the disease. So if you have a random individual walk into your clinic, you have a 0.3 proportional 30% probability that you actually pick or you have a chlamydia patient in front of you. Whereas if you use the same approach in a private practice, you essentially get a predictive value of negative of 1. So this is like virtually an inexistent deviation from 1. So there's actually 1 false negative, but given that we have 941 true negatives and we're dividing 1 by 941, this positive predictive value is exactly, it's very, very small. So 941. So it's 941 divided by 942. So this is very, very close to 1. So on the other hand, we have a very low number of actual positive cases. So those that tested positive are essentially very much balanced by those that tested positive but are actually negative by our false positives. So we get 29 divided by 58 is 0.5. So this emphasizes already that it really matters which population you're actually employing the testing. Any questions to this graph? To this table? If not, then let's carry on. So it's really important at this point to also define some terminology. So essentially you are, and this will down the road, if you continue in the realm of biostatistics further, you will be using terms like stated here. So you will talk about an event, which is essentially a measurable, a definite outcome of interest in your statistic, in your analysis, in your analytic approach. So essentially, if you have an individual with a chlamydia infection, this would count as an event. In coding terms, you would essentially code this individual as a 1. So you literally get one row that stands for one individual, and you assign a 1 when it comes to the outcome column. A second event could be that an individual survives past 70 years of age. So event does not necessarily mean it needs to be a disease. It doesn't mean it needs to be something negative. It also can be something positive. It can be that the individual survived. It depends on the question that you analytically ask your data. That determines whether you're going to assign a 1 or a 0, or it basically defines what your event essentially is. So it can be survival, it can be disease, it can be death. Survival analysis essentially also counts death as an event. Analysis of hospitalization counts hospitalizations as a 1 in the simplest case. So when it's an analysis of time to first event, or time to first hospitalization, you would essentially count a 1 for event. And in the very same context, the probability translate into the rate of an event for a very large number of observations. This means that we're talking about the probability of getting chlamydia as a percent or fraction. Important with this is to keep in mind that the probability of getting chlamydia here in this context is captured over. Were you not able to see my screen before? Are you able to see my screen?
Yes, Professor, your screen is visible. Your audio went off for me. That's why I have to rejoin.
Is the audio visible? Audible? Can you hear me?
Right now it's audible. In between it was gone for me.
That was the internet again. Which part did you not hear?
The previous slide, most probably, because this went off.
This one with the table?
This one I listened. The next one after this.
That one?
Yeah. Yes.
So you were not able to hear that?
No.
Oh. So, but you cut from the table, you cut false positives, right? So that's an incorrect positive test. Then you have false negatives. That's an incorrect negative test, right? So the performance of tests depend on the population it is applied to. And the comparison to gold standards, essentially, gold standards are highly accurate and expensive and invasive tests. This is why it's important to understand the performance of the test within the population. So you didn't hear anything of this?
I got it now. I had some part of it, and then some part of it just went off for me.
Ouch. Sorry for that. This has got this patchy internet here. I don't really know what to do. How about you guys? And do you have the cameras on, or can you also turn the cameras off?
Our cameras are off, Professor, but it's actually dependent on the reception that you are getting. Then what transmits from your reception is the main important thing than what we are doing here.
Okay, so this is really, yeah, sorry for that. So turn your cameras off and let's carry on for now. I think this is the only thing that we can do at this point. Okay. So we talked about this: true positives, true negatives. Positive predictive value depends on the actual population you're using it in. We're having events that basically has either an event like an infection or a positive event like a survival over a certain period of time. And we have probabilities. So the probabilities of contracting a disease or the probability of having an event, which in this case is actually a positive event. So we have now to distinguish between properties of a test and properties of a test in a population. And for the properties of a test, and this is now different from the positive and negative predictive value that we discussed before, which changes based on the prevalence that we are actually looking at in the population we're employing the test on. So sensitivity is in contrast to that, specificity as well. So the sensitivity is essentially, as per definition, the probability of a positive test for a group of individuals within your overall population that actually really has the disease. Whereas specificity is the probability of a negative test for individuals that do not have the disease. So this is an important distinction to make, and it really is very exclusively to be seen in the context of the test per se, independent of the population. So now to test this now in an actual use case, we're looking now at type 2 diabetes mellitus. I don't know how much you know about diabetes, but essentially diabetes is a disease. Type 2 diabetes is essentially caused by what is called insulin resistant. So essentially usually you have glucose as something that provides energy to the body. floating around and circulating within your circulatory system, providing energy to your cells. So insulin will dock onto cells and will open specific channels that allow the glucose to enter the cell and be available for metabolism in the cell. If patients are insulin resistant, that means that they cannot work with the insulin that essentially is circulating, and the glucose will not enter the cell and will be available for metabolism, but it stays in the bloodstream. As a consequence of that, patients with diabetes present with higher levels of glucose in their blood. This has a lot of side effects, as you probably know, at least a few of them. Causes atherosclerosis, active inflammation of the vessel walls. So there are there are a plethora of consequences to diabetes. Diabetes is very highly prevalent in the older, particularly on the obese US population, not only in the US population, the population worldwide. The gold standard to essentially diagnose diabetes or elevated glucose or an elevated or an impaired reaction to a glucose stimulus is an oral glucose tolerance test. So essentially, in this case, the patient would drink a solution containing glucose, and you would measure right before the patient drinks the glucose. Then you measure in certain frequencies. You measure this again. You measure again the serum glucose, and by that you know how quickly the glucose disappears from the bloodstream and is being taken up by the cells for metabolism. And this is essentially a reflection of insulin resistance or insulin sensitivity. So now, as you can imagine, this is a laborious test, right? Because you can't just do this once. You need a blood glucose meter. You need to take the solution. You need to take the blood samples. You need to measure those blood samples. So this is laborious. This takes long. So that's why it was necessary to essentially find screening tests. One of the screening tests that is essentially accepted from the American Diabetes Association is fasting plasma glucose. So this is, for example, when you go to the doctor and you do your annual checkup, which I hope you all do. You go there and they tell you to not eat or drink 12 hours before you come to your visit. They take a blood sample and they will measure glucose. This screening test is easy, fast, convenient, and it actually predicts the gold standard of the oral glucose tolerance test with acceptable certainty. For this very reason, it became very popular, and it's essentially state of the art to go for fasting plasma glucose instead of the oral glucose tolerance test. So now imagine two groups. You have diabetics and you have non-diabetics. You have 20 diabetics and 20 non-diabetics. You have blood sugar levels from high to low. They all have a point, and they all have a value somewhere in this range. The diabetics slightly higher and a little bit more skewed to the lower, so negatively skewed, whereas the healthier ones are rather positively skewed, but still some high ones. So now you want to analyze in these whether they likely have diabetes or not. So you need to first determine a threshold. And this threshold will essentially lead to you classifying patients as either having a positive test or a negative test. And this is the plasma glucose. And diabetics and non-diabetics is essentially diagnosed using the gold standard. So your true positives essentially are these 17 guys here, whereas your true negatives are actually these 6 here. So now you have 6 divided by 20, which is the marginal total here, which 14%, and 14 and 6 gives you a specificity of 30%. So this means this is the probability of somebody with a negative test result amongst those that really do not have the disease to produce a negative test result. So this is specificity. Then you have sensitivity, which has the opposite kind of interpretation, which means these are those with the disease that actually do have a positive result. And it comes with a sensitivity of 85%. What's the problem? You're missing 85. You're missing 15% of those that essentially do have the disease with your 3 guys here. So you have 3 false negatives and you have 14 false positives. So this is a problem. What do you want to do as a consequence of that? You want to go higher. You want to increase your specificity, which is awfully low, with 30%. So you want to essentially diagnose with more certainty whether those that do not have the disease actually test negative. So for this reason, you need to increase the threshold, which essentially will give you a more conservative estimate of who is non-diabetic or not. And for this very reason, you increase the threshold. As a consequence of that, you even get more false negatives, but you also get more true negatives. Problem with that is, and this is the trade-off I was talking about, you have now a specificity of 90%, but you're losing 60% sensitivity. You're down with your sensitivity to 25%. So this is a problem, right? So this is this trade-off why it's important to really understand what population you're employing it in and what the performance of your test is. And that's the next issue, because in a typical population, you would not have this line separating the 2 groups, and they're all mixed. They're all over the place. They may have high blood glucose, and you may essentially misdiagnose them. You may misclassify them. So it's very complicated to really diagnose who is in which group. So all of this has to be seen with no color, no label. You have a random person entering your office and you're doing a plasma glucose in fasting state. So the higher the cutoff, the more likely you will have healthy individuals. The problem is you may miss more that actually do have the disease. The lower the threshold, the more you will catch as or diagnose as being diseased, but you may essentially overdiagnose quite a few. So now you have, this is exactly what I said. So you really have to keep in mind that these cutoff points yields different sensitivity and specificities. So it really determines how many subjects you will consider as having the disease or not having the disease. And this is important to keep in mind because you will now learn about the second part of it, and we talked about it briefly. So the positive predictive value is a probability that someone with a positive test result has the disease, whereas the negative predictive value is the probability that someone with a negative test does not have the disease. Negative predictive value here would be 18 with the high threshold, 18 divided by 33. This is not too, let me quickly calculate this. 18 by 33 is, here. 18 divided by 33 is 54%. So essentially here you get 55% of negative predictive value. That means that those that test negative, you can only be like certain with 55% probability that those that tested negative are actually real negative. Whereas if you do 5 divided by 7, this is 71, you actually can be fairly certain that those that test, well, fairly certain. So with 71% probability, you actually can say that those that test positive do indeed really have the disease. So this emphasizes already that there are differences that are determined by the prevalence in your population. And so 71 versus 25, and 54 versus 90 is basically driven by the population. But then also it causes great debate, because if you have positive predictive values and you're starting to overdiagnose, it has been under a lot of scrutiny, because you get some certain diseases are very, very frequent. When they're very, very frequent, positive predictive values also do have a lot of inaccuracy. So there's a lot of debate about these, particularly in the context of tests that do not have high specificity or sensitivity. So it's really, you need to understand both properties. You need to understand the properties of the test and the properties of the test in a certain population. And this is, so these are really, particularly I remember when I was at medical university here in Austria, a large conversation went around mammography. So essentially a positive predictive value of a mammograph is actually considerably high, but it's also the prevalence is considerably high. And you are basically, if you're overdiagnosing somebody with a disease like mammocarcinoma, and you essentially breast cancer, you essentially, and you start essentially with invasive procedures, you're causing a lot of distress, you're removing tissue, so it really becomes a very invasive process. But then on the other hand, you have the offset and the discussion whether this outweighs the risk of actually overseeing and missing breast cancer. So it really is a great debate when to use which test and to what extent put weight on the diagnosis made of certain tests, particularly with those that are considerably highly prevalent. So any questions on that so far? I think the principle is considerably understandable and considerably intuitive in a way. It's just the way you're employing it becomes somewhat tricky at times. Okay, so we have, then we can carry on to probability notations. So we talked about this in, I believe, the first or the second class. So we have A union B, that means like it's A or B. We have A intersection of A and B. We have A and B. Then we have AC, which is A complement, which is everything but A. So it's not A. So PA and PAC will always be 1, logically. And now, and this becomes important for the next slides, PA conditional B, which is the probability of A occurring conditionally on B being true. So this is a conditional probability. So now this essentially goes now in the realm of Bayes' theorem and conditional probability and the determination of a post-test probability based on an existing pre-test probability and the added employment of a test on a certain population with a certain pre-test probability. So if we have here the Venn diagrams, so here we have intersection of A and B with union of A and B. So here we have the intersection of A and B, which is A, B. This is the intersection of A and B, which have both characteristics. Then we have A, B, and C with, again, A intersection B, B intersection C, A intersection B, and A intersection B intersection C. So this is where all three intersect. Then we have mutually exclusive events, which we have discussed. We have talked about these quite extensively, actually. So we have P chlamydia positive and or chlamydia negative, which is the same as probability chlamydia positive and chlamydia negative, which essentially is 1. Then we have P chlamydia positive and negative, which is again 1. And then we have P chlamydia positive and chlamydia negative is 0 because they can't have positive or negative at the same time. So this is along these lines, you have to consider these probabilities and the application of prevalence and population on probabilities and prevalences on populations. Then we have non-exclusive events. We talked about these. That's heart disease and chlamydia now. So we have here intersection, and we have chlamydia and hypertension, which is here basically the intersect. If you have two independent events, so if you have this intersection, it's interesting and important to keep in mind that this will essentially be able to be added. So you can add these probabilities up. Whereas if you have independent events that have nothing to do with each other, you actually can multiply these probabilities. So you have the probability of chlamydia positive and heart disease will essentially be the same as probability of chlamydia multiplied by the probability of heart disease. So this is important to keep in mind because this we will need for later examples. So good. So now we have the conditional probability, and now I will briefly talk about these, but I'm going to cut it short on this aspect. So essentially here we have the probability of A intersection B over the probability of B. So the probability in the denominator is the given event. So it's the times that B occurs with the proportion of times that A also occurs. So this becomes the conditional probability, and this is really based on Bayes' theory, which is interesting in this context to keep in mind, because essentially this was a test that Reverend Thomas Bayes did in the 18th century, where he actually was estimating the position of a red ball by rolling blue balls without looking, blinded to the table. He would roll blue balls, and you just had an assistant tell him the location of the red ball in reference to each ball that he rolled, and by that he was able to kind of find to the location of the red ball without ever looking at the pool table. And he did that, and he conducted mathematical experiments to actually come to Bayes' rules, where you essentially can, based on the prior probability, the pre-test probability of pain, to essentially quantify whether the individual essentially group control did not have pain and was essentially pain and the normalizing factor. So you have to keep in mind that when you have a sequence of events happening, so back to the diabetes example, so you have a certain probability, which is here essentially our A. So this is diabetes. This is the measurement of diabetes and a positive test. And here we have no positive test. This is the entire group. So essentially, we are now having two independent events. So we're treating this as independent events. We're getting the probability, the proportion of both of these events to happen. That's why we're multiplying it and we're dividing it by the entire group, the control group. That essentially normalizes this to the overall population. So it is just important that you really see this in the right sequence, because the pretest probability essentially is a probability that requires an assessment within a population. You need to understand this population. And this is essentially also given the sequence of events. So you first have the population, you have an estimate of the prevalence in this population, and then you're employing the test. And essentially, this is how you get to a conditional probability. So equality can only be if both of these are the same, but essentially this is the chain of events and the sequence in which you have to look at your assessments. So it's really the probability you would require that you have as much money, or the probability that you have as much money given that you're retired. So it's, you have to think of it in that way and fashion. So this is the pain example that we had from lecture 1. And essentially this was what was new, was what was used before. So we have the group treatment, we have pain equals mild, so we have mild pain and group treatment, or we have group treatment and mild pain. So essentially we need to understand which one is actually which one. So we're testing for the assignment within the group. So this needs to essentially be in the first rank of order. So it's the treatment and then the pain, not the pain, then the treatment. So application of a screening test, essentially. So we have talked about this first. So we know now the prevalence of our chlamydia infection in an STD clinic. And for that very reason, we are now employing the prevalence, which is 300 out of these 1,000 individuals. We're calculating now A divided by A plus C, which is 294 divided by 300, gets us to a sensitivity of 0.98. So essentially this becomes now a factor that essentially will be factored in to get us to sensitivity and specificity. And this essentially will now be closer to the positive and negative predictive value. And it basically allows for us to calculate based on sensitivity and specificity, knowing the prevalence, the pre-test probability, to calculate the post-test probability, being closer to the positive and negative predictive value, and being more accurate employed to the population than both of these. So this is basically how you use a characteristic, a performance characteristic of a test, and you are employing it to a population where you do know an estimated prevalence. The charm of this is that with this formula, you can use these formulas to estimate what performance your test will have in different populations. So this is why it's important to also not just rely on the positive and negative predictive value, because you also want to understand and you want to simulate and understand what your prevalence essentially, what effect your prevalence will have on your test and all the outcome of your test. For this reasons, essentially, you can use Bayes rules calculator, which essentially allows you to give you estimates on that. And again, it's the same example calculated through, gets you down to 50% here. Good. In conclusion, and this is important, so the probability of having the disease given a positive test result does not equal the probability of a positive test result given that you have the disease. So you need to understand what the population looks like. You need to understand that a positive test result does not always mean you have the disease. And but again, it's as a screening tool. Essentially, it is employed in a certain way that will prompt further assessments given on thresholds that have been determined on the application of that test. Good. Again, just as a brief recap, so we have the properties of the test with sensitivity and specificity, also labeled as true positive rate and true negative rate. And we have the application of the test to the population as the PPV and MPV. They are related to Bayes rules. So Bayes rules essentially gives a more accurate estimate based on the prevalence estimates, but they're not the same. And this is notations. Okay. Was that clear to some extent? Or are there any questions on that? If no question, then we can carry on to the lab, which is we're only having 10 minutes left. So this is rather disadvantageous. So that's the problem with the quiz. Okay. So the lab today essentially is, so if we do now BTM6000. So we're doing in today's lab, we actually were building practice lab 6. So we have this today, we have to download the enhanced subset, which essentially will now allow us to load it into R. Modular. Okay. Six. Okay, so it's over. You can just quickly hashtag that out. So what we're doing today is actually quite important for the development of the graded lab. So it's really important that you do pay particular attention to this development of, okay, so we want to do, this one. Okay, so we want to do two things. We want to categorize the cohort in secret distribution action. So we have essentially quite some things to do. Well, let me actually, can you see my screen?
No, Professor.
Okay. Let me quickly download code. I'm gonna make it a little easier.
Professor, can we actually have this, like, could you send the recording of the lab, because we have another class starting in 3 minutes, 3 or 4 minutes.
Oh, really?
Yeah, we have a class again. It starts around 6:55, between 7.
Okay,
between 6:55 to 7, the class starts. Another one.
Yeah, I just, yes, I sent you the code. Let's do this. I'm downloading it as we speak. The only thing that's important to keep in mind is you will need, okay, I'm posting it as an assignment. As an announcement.
Sure, Professor.
Yeah. The only problem to understand.
Yeah, I feel
you need to understand what actually each of those things mean.
Is it possible that you could send us like a brief video explaining what to do in the lab? Is it possible?
Yeah, let me do this. Yeah, I will stay on and I will finish. I posted as an assignment announcement, and you can walk through this. I walk for the rest of this lab now through the code, but you can drop off whenever you think you need to go to class. Okay, so essentially when you look, sure, that's fine. So what is important to keep in mind? So if you are essentially loading the code into your R, you will need to do just as we always did. We are essentially just loading the subset file. CSV. Please make sure you're gonna review all of this for the graded lab. I don't want you to struggle in the graded lab. I think that's gonna be next class. And so we are essentially loading the subset with the common read.csv function. So we're calling this df read.csv. This is essentially that file we have here. So when you look at this code that I have posted, so you can basically easily just inspect it. You know, these are the actual variables. This is the histogram. These are the summaries. You need to be careful because you have 77 NAs, so you have missing values in your file. So you can address rows and columns exactly in this way and fashion, but you know all of this. We have done this quite extensively. So you know how to extract these variables from the data frame. Then it's also important that you remove the missing values. So this is the data frame removed after 7. It's stripped of those 77 missing values. So it's basically it becomes a subset where this is not NA. This is the exclamation mark is not NA. So this is important to keep in mind. So essentially, you're creating now a new variable that essentially does not contain, which essentially does not contain the NAs. We are now classifying as per the EGFR, which is which is something that was not done. So this is now CKD new factor. We are essentially getting now no CKD and CKD. So we're getting CKD 79 chronic kidney disease patients. We're getting 844 with no chronic kidney disease. And now we're creating one that is serum creatinine, and we're also classifying this in elevated or non-elevated. So this is now essentially the same approach. We have a summary DF serum creatinine elevated, gets us not elevated and elevated, and allows for us to create now this contingency table. This contingency table essentially is now serum creatinine elevated, where you need to re-level. This is a new function that we haven't discussed first. So serum creatinine elevated is essentially that very same codes, that very same variable. We're re-leveling this, and we're making now elevated our reference category. This is important because this will affect how it essentially will put them in a table. So we're doing the same with CKD new. This is a new factor. And the next is essentially now creating a table. It's contingency table with table DF serum creatinine elevated and DF CKD new factor. This essentially becomes now C table. That's our contingency table. And you see this follows the same outline as the one we've seen in class. It's CKD. Column 1, no CKD, column 2, test positive, row 1, test not positive, row 2. And this is because, so we needed to re-level the reference groups because otherwise you would have arranged these in a non-useful manner for us, a non-useful manner to us. And now essentially it's just a calculation of sensitivity and specificity. So we have contingency table 1, contingency table 2, and contingency table 1 as a sum. So by this, we essentially easily can calculate sensitivity and specificity, which gets us into 85 and 96. Sensitivity and specificity. So then we have a created contingency table. This was the former thing which we can bring up. This is here. Okay. Then we have here calculation of sensitivity and specificity and with construction of the Roc curve. Yeah, so I leave you PPV and MPV to do. So you see here how that works with MPV and PPV. I leave that for you to do. And I will check that you're doing it. And I will to that point if it was not done. And then we have here the receiver operating curve. And this is an interesting one. So we need for this an installation. We need to install the Proc package. That's an interesting one. Okay, so for those of you that essentially also installed R lately, we'll run into the same issue. I will find a workaround for this. Okay. That's interesting. Okay, I cannot show you a Roc curve, but what I will show you is a ROC curve. So a ROC curve essentially is a curve which is called the receiver operating characteristic curve. For those of you that do go further into data analytics, you essentially will need a Roc curve, because this is a very common kind of way of diagnosing and analyzing the performance of models in machine learning. So essentially what you have here, so you remember how we discussed sensitivity and specificity as a true positive and false, we talked about, so again, so we have here sensitivity as a function of 1 minus specificity. And by that, we get this curve. So let me find. So you remember how we talked about the contingency table here. So here we have true positives. Here we have true negatives. Here we have true false positives. So these are actually not infected individuals, but they test positive. Here we have false negatives. So now essentially we want to now plot the true positive rate, which is the sensitivity. The sensitivity is those that are positive and the performance of the test, and those that have really tested positive in the numerator, and those that are positive in the denominator. So these are the true positives, and the sensitivity is the true positive rate. So in comparison to that, we have now on the x-axis, we have the false positive rate. The false positive rate is essentially false positives are those that tested positive but are essentially negative. So these are the false positives. So we need to calculate the specificity, and 1 minus the specificity will give us the rate of these people. So alternatively, you can calculate it as 29 divided by 970, but essentially specificity would be 941 divided by 970, which is considerably high of 0.97. So 1 minus 0.97 gives us 3%. So that would be our true false positive rate. And plotting this over an entire range of data will essentially show the characteristic of this area under the curve and the probability of testing correctly over an entire range of thresholds. So all of these are thresholds because essentially this will be the trade-off between the true positive and the false positive rate will be the shifting of the threshold. And you remember how the diabetics were basically shifted, and we shifted the threshold higher or lower. And this is exactly what happens here. So we're shifting along this line, we're shifting it higher to essentially get to a true positive rate that is at 1 and get essentially a high false positive rate that essentially increases with the true positive rate because we are classifying more and more and more as positives. And this is a function of 1 minus specificity. Good. I just wanted to show you the Roc curve. I will look for a workaround to solve this problem because you likely also have all new versions of R. Okay, but this was all. I posted now the current code, the solution of practice lab. There's an announcement. The only thing for you to do is to essentially go through the code, understand the code, study the code, and also to calculate MPV and PPV. Good. So see you next week in person on Thursday at 5:30. All right. Bye-bye. See you next week.